Twan, shall I introduce you?
Well, you can if you want.
Okay.
So it's my great honor and privilege to introduce Professor Twan Lammers from Aachen, RWTH Aachen. Twan is, I think, one of the, not only I think, actually the CRS just recognized that, is one of the leading scientists in the field of nanomedicine and drug delivery today, looking, I think, at the hard questions we have in how nanomedicine would actually be effective and where nanomedicine may not be the best choice. And Twan isn't ever afraid to ask those questions. That's what really makes him such an amazing scientist. Twan, please.
Thank you very much for a great introduction. So we indeed try to answer some of the hard questions while keeping, I would say, pragmatic solutions in mind. So we definitely cannot answer all of these questions, but at least, for instance, using imaging, and I'll talk about image-guided drug delivery, in particular in tumors and metastasis, I think we can make a step forward with regard to selecting the right patients for the right treatments. So everybody in this audience knows what nanomedicine is, so I can go very fast over this slide. The carrier materials which aim to improve efficacy, reduce toxicity, and they're largely relying on the enhanced permeability and a retention effect. There are a bunch of different strategies that are also being evaluated, but in particular in the clinic, most of these materials, and also, for instance, actively targeted formulations, they rely initially on long circulation, extravasation, penetration, and then binding. So EPR is very important, and EPR is very variable. If you look in the clinical situation, in humans, sarcomas, Kaposi sarcoma is a very prototypic cancer that is known for its leakiness. These types of tumors tend to be very well targetable using EPR and passive drug targeting. The funny thing is, there is a big difference between animal models and patients. So if you look at dogs, for instance, sarcomas in dogs, which spontaneously develop in Labrador dogs, they tend to be very unleaky. So you really cannot generalize things. And also in human situations, head and neck cancers tend to be fairly well targetable using the EPR effect, whereas, for instance, breast cancer, so this is the primary breast tumor here, this is a metastatic lesion. Breast cancers tend to be fairly stromal, and in that case, it's pretty difficult for nanomedicine to gradually accumulate in such tumors over time. And in this regard, it is important that if there is a sufficiently high degree of EPR, I'll skip this slide, if there is a sufficiently high degree of EPR, like in Kaposi sarcoma, there is also high efficacy. Right? So there has been a pivotal trial performed more than 15 years ago already in which they compared liposomal doxorubicin, Doxil, head-to-head versus a triple chemotherapy combination based on adriamycin, bleomycin, and vincristine. And in that trial, actually, there was a doubling of the efficacy. So there was one complete response and about 60 out of 130 partial responses in these Kaposi sarcoma patients for just Doxil, whereas in the case of the triple chemotherapy combination, there were only about 25% of the patients which were responding, which actually shows that if you have a high degree of EPR, you tend to have a high efficacy. And vice versa, if you look at breast cancer is, again, we cannot generalize, but breast cancer tends to be characterized by a fairly low degree of EPR. And what we know in breast cancer is that Doxil does work, so it does improve the tolerability of the treatment. Patients like it better, but patients that are treated with Doxil do not necessarily survive longer. They do not necessarily show higher patient responses. And this really shows that by imaging the EPR effect, ideally even doing this upfront, prior to selecting whether we want to treat a patient or not, we can really make a difference at the treatment efficacy level. And we're actually trying to verify this in animal models. So we take, for instance, polymeric mice cells, recently published by Yang Shi and Wim Henning in Utrecht, which are labeled with a near-infrared fluorescent dye, which we then inject into a whole cohort of mice bearing tumors. We follow during the course of treatment. We treat every week for 3 to 4 weeks. We follow whether the formulations actually accumulate in tumors, and if they do, does this accumulation correspond with efficacy? What you essentially also see here is that if we have tumors, so this is where the tumor is, if tumors have a fairly low degree of accumulation via the EPR effect, we see that actually tumor growth during time, so these are 5 different tumors 3 weeks after the initiation of therapy, that tumors in this cohort are significantly larger than the tumors here. So here in green, actually, you have the tumors behind the fluorescent clouds that indicate efficacy, that indicate accumulation. And also in this case, we have the impression that if you have a good accumulation, you get a better therapeutic response. This is an opposite result, which actually also nicely shows the need of using imaging to ideally pre-stratify patients to treatment. There's a formulation called PK2 for PROC-KEL2, which is based on an HVMA polymer with doxorubicin. It's targeted to the liver using a sugar moiety, galactosamine. This is the non-targeted, the passively targeted formulation, where there is barely any accumulation within the liver of this patient. And this is the actively targeted formulation. And based on these whole body images, you would expect that there is fantastic efficacy, right? We're having a lot of drug within the liver. But if you actually zoom in on the liver, this is an anatomical CT image where you have the healthy liver parts over here on the top. And this is in the central part, you see the tumor. And this is where the probe goes. So actually, in this case, what you can really see is that within the tumor, there is some accumulation. It's not black, but it's definitely much less than in the whole liver. And it's arguably not enough to get a good therapeutic response. And this explains why in this trial, there were only 10 to 15% of really good responses, partial responses in hepatocellular carcinoma patients. And it really exemplifies the need to combine drug targeting and imaging. This was just exemplarily done for a couple of patients to show that we can actually target to the liver and also within the liver quantify actually using regions of interest how much of the drug goes there. But if you would really systematically integrate this in a, let's say, in a first patient pre-selection setup, you could exclude patients which have, for instance, less than 1% accumulation or less than 5% accumulation. And the idea here is that we combine drug targeting and imaging, in particular to facilitate clinical translation. I think for that part, it's most important. If you're a young startup company, if you have a formulation that works well in a number of animal models, and then you go to the clinic, right? We know it circulates long, we know it can do EPR if EPR is present. If you then, without imaging, go into a cohort of, let's say, 60 patients, and you would treat all of them, and 30 or maybe even 40 of them would not even show any hints of EPR, then probably the end result will be that your treatment does not work. And that's not because your formulation's not working, it's because you're not reaching your target site. Right? So there's this idea where you can differentiate initially on the basis either of a companion diagnostic or a labeled nanomedicine formulation. You inject this during the first course of therapy. Then you select those patients that show a good accumulation. You start treating those with the nanomedicine formulation in question. You can include a second patient selection step, which can rely on imaging or on other biomarkers. And if the setup works, if there are hints of efficacy, you can circle the patient for a number of treatments with nanomedicine treatment. And equally important, if you have patients like this one or this one or this one, which does not have a high degree of EPR, you can exclude them from nanomedicine treatment already from day 1 or week 1 onwards. And you would not treat patients without good accumulation at the target site in vain for, let's say, 6 to 8 or 9 months with a treatment that is very unlikely to work. And what we're actually at the moment trying to do is really to transfer this situation to beyond solid tumor targeting. It is, I think everybody knows that most cancer patients are not dying of solid tumors, they're dying of metastases. And in the case of metastases, imaging might even be more important. Right? So if we do a pre-scan, let's say based on FDG, glucose-based PET imaging, we know that a patient has, for instance, one big tumor, 4 or 5 different metastatic lesions. If we then take a companion diagnostic or a labeled nanomedicine formulation, we can get situations which are like this. It's probably never as good as this, with a patient accumulating at all sites very efficiently. Hopefully, it's never as bad as this, with a patient not accumulating nanomedicine within any of these lesions. And based on the imaging information we get, we can come up with therapeutic strategies, with regimens on how to best treat the patient and to decide whether we include nanomedicine or not, whether we want to turn, hopefully in a couple of years, to immunotherapy to get a grip on metastasis, and so on. And you can envision something, for instance, for this case, where the primary tumor does not accumulate nanomedicine very well. Several metastatic lesions at different sites do accumulate nanomedicine well. You could then use nanomedicine treatment to try to get a grip on the metastasis while you treat the primary tumor with radiotherapy, with surgery, or so on. This situation actually is not what we're finding in preclinical models. We're really asking the question, how efficiently can we target metastatic lesions using nanomedicine formulations? And in order to do that, what we, together with Larissa Rizzo, have been doing is we are working on a 41 metastatic breast cancer model, which we implant orthotopically. So we take 41 cells, we actually transfect them with an IRFP. It's a near-infrared fluorescent protein. It's like GFP, but in the near-infrared range. We induce the tumors locally within the mammary fat pad, so orthotopically. Then we wait for 6 to 8 weeks. And the mice gradually develop a number of metastases. And this is a very aggressive model. So there are always a number of metastases all over the body of the mouse. In particular, within the lung, we always see a large number of nodules. On the rib cage and in the bone, we often get a lot of nodules. Lymph nodes tend to be positive for metastatic cells on many occasions, and also several other sites. And the advantage of doing this technique is based on computed tomography together with fluorescence molecular tomography. The nice thing of this is that we already have intrinsic information based on CT on where the metastatic lesions in these mice are. So here you have a lung, right? This is a 2D CT slide. This is a 3D reconstruction, which you can actually do semi-automatically. So it takes like 5 minutes and a couple of button clicks to get this information. And based on the differences in density of metastatic lesions versus normal lung tissue, CT can tell you where the lesion is, how big it is, what the volume is. And we can very nicely use this over time, in particular also using treatment, to evaluate therapeutic responses without having to kill these mice. Okay, so this is a very busy slide. I'm just going over it very rapidly to explain what the setup is. So we take the cancer cells. They're labeled with this near-infrared dye, protein, which fluoresces at 680 nanometers. We take liposomes, which we double label. We have a 488 dye and a 750 dye. We inject the liposomes into these mice as soon as they have significant numbers of metastases, and then we do co-localization studies, right? So this is how the liposome picture looks. This is where the metastatic cancer cells are. And in vivo, for instance, you see that the primary tumor is here. There's a large subcutaneous neck lesion, a neck metastasis here. And this is actually also where the liposomes go. So we see that they're in this neck lesion. We see that they're in the primary tumor. We know that they're also in liver and spleen. But when you then look at lung, right, or in ovary, we have a metastatic bump here in the ovary. You see a large accumulation of liposomes also in the ovary in the metastatic part. And a similar information actually for the lung, which is even more nicely depicted here. So if we have within the lung a number of metastases, this is where the cancers are. So these are healthy parts of the lung, right, on the bottom and the top. The metastatic clumps or bumps are in the central part of this lung. And this is really where the liposomes go. They do not go to the healthy parts of the lung. They do target the metastatic lesions quite efficiently. We see the same thing in liver. So this is where 2 small liver nodules are. I have to say that this model does not very extensively metastasize to liver. So we only have this every now and then. But if it happens, we do get fairly good accumulation. And similarly, for all these systemic metastases that we're seeing in different types of lymph nodes, or we sometimes even get clumps in the spleen, we have mesenteric metastasis, ovarian metastasis. There's always a good correlation between the accumulation of liposomes and the presence of metastatic lesions. And what we're most interested in is to really understand how the localization of metastasis affects accumulation and how the size of a metastasis accumulation affects accumulation. And in particular also how the vascularity within different lesions correlates to accumulation, because what we are assuming is that the vascularization of a lung metastasis might be completely different from a brain metastasis or a liver metastasis. So in order to do that, this is just very simple ex vivo fluorescence reflectance imaging. We're also doing this with CT FMT in 3D in vivo and ex vivo phantoms to get something in percent injected dose per gram of lesion. This is what fluorescence reflectance imaging does, right? It is useful because you can compare healthy tissues to metastatic lesions to solid tumor, but these units do not really tell us anything, right? But with this technique, we cannot get a grip on percent injected dose. The main message here is that what we always find, and this is actually quite surprising, as you'll see in the next slide, is that the tumor accumulates most efficiently. Many of you might have thought that, but on the basis of what we see when it comes to blood vessels, we would have expected that metastases accumulate much more efficiently because metastases have many, many more blood vessels than tumors. Metastases are always somewhere in between, right? So if you compare healthy lung or healthy liver, they're down here. Metastatic lesions are 3 to 4 to 5-fold higher in accumulation than the healthy lesions, but they're always only half of the solid tumor. And that is really surprising if you look at the vascularization in different types of metastases. Just take a look at this 3D volume rendering of vessels within a solid tumor. So in red, the vessels are depicted. In blue, you have some sort of a depiction of the volume. If you look, for instance, at this neck metastasis, 20% of the volume of this metastasis, right? If we quantify it in percent, the relative blood volume, 20% of the volume is vessel. And these vessels are young, right? This lesion is 2.5 millimeters. These vessels have just sprouted. They're supposed to be angiogenic. So we assumed that they would be leaky. But we're only seeing half of the accumulation in these vessels, right? Whereas in the solid tumor, where we only have, in this particular case, we only have like 2-3% of the volume being a vessel, we have a much higher accumulation. I'm really wondering why that is. So if you have any good ideas, I'd be more than happy to discuss it with you afterwards. This is just to give you an idea of the vessels in the metastasis. So this is the solid tumor. This is a metastasis. This is actually 2-photon microscopy, which is really nice because you can intrinsically look at collagen. So you also get an idea for the stroma within a tumor. Liposomes are in green, so there are some liposomes throughout this lesion here. Blood vessels are in red, right? And this is a bone metastasis, which has, I thought it was 14 or 15% of the volume being metastases. They're fairly well distributed. They're homogeneous within the lesion. They're well perfused because this is a perfusion marker. It's a labeled lectin, FITS labeled lectin, a rhodamin labeled lectin, sorry. And on the basis of this, we would expect to see green signals all over the place because there are so many vessels, and these vessels were assumed to be so leaky that we expected to see much more liposomes. We actually don't. And we don't really know why that is. Probably the dynamics here are much more strong than in a tumor. Much more is coming in, but also much more is going out again. So arguably, retention might be a component that is a little bit lacking in metastases. And if we want to create retention, we might even consider doing active targeting, because what we know about active targeting is that it can increase the retention of compounds, of nanocompounds within tumors. Good, and we're also trying to, last slide, to treat metastasis. This is the first experimental setup that we did. We took a core cross-linked polymeric micelle in which we covalently entrapped drug molecules. We take the same tumor model. We treat it either with 3 different doses at 30 milligrams per kilogram or a single dose of 90 milligrams per kilogram. My cells, as compared to docetaxel, responded better, both when it comes to primary tumor growth and when it comes to metastases. So we do some histological validations. We do this in vivo CT technique where we can detect individual bumps in the non-treated controls and the vehicle-treated controls. And we try to really get an understanding for under which situations and for which types of metastases we get a good targeting and a good treatment efficacy upon using nanomedicine formulations. So as a take-home message, I think drug targeting and imaging as a combination really makes a lot of sense. It makes a lot of sense because it tremendously facilitates preclinical research, right? All these metastases studies could not really well be done if you do not use non-invasive imaging. You would need a lot of animals. Probably the answer at the end would be the same. It works or it doesn't work. But if we want to dig in, if we want to understand why we can target or why we can't target, and imaging might really help, I think it also is very useful for facilitating and improving clinical translation if you want to select the right patients to treat in your phase 2A or 2B trial. And in clinical practice, it might really lead to personalization, right? If you can assure for a patient that during the course of treatment, nanomedicine keep on accumulating, they keep on being efficient, it really helps to individualize the treatment of patients. So with that, I just wanted to say that we have a meeting in Utrecht. It's the European Society for Molecular Imaging, which organizes a molecular imaging meeting there. It's organized by Krit Monen. And we will have a whole day of educationals focusing on image-guided drug delivery and nanomedicine. Take a look at the website if you're interested. It's in March next year. And I would be happy to see some of you appearing there. The first plenary speaker actually just confirmed. It's Peter Radcliffe. He's a worldwide expert on hypoxia and angiogenesis and HIF signaling. So if you're interested in the field, please take a look at the website and come over. Finally, I'd like to thank the people that I work with, the people in my group, in our whole department, some international collaborators, the agencies that provided the funding. In particular, also this guy here. I assume he's not in the audience. He always tends to walk around at the coffee machines. And he always tends to give out dwarfs to people that I think in many cases do not deserve them, whereas he should really deserve, or he should really get a giant, because this is really his conference. He organizes this. He gets the people here. He gets the good talks. And, well, I wanted to give an applause for him, but he's not here anyway. So let's just stop here. I'll take any question. Thank you. Yeah. Please, in the back.
Okay, thank you. Twan, it's a nice presentation as usual. Of course, I think the evaluation of EPR effect is a mandatory, I think, perspective for the future. Probably it is not enough. I think that just because in this way you can stratify lesion, but you cannot change the results of a certain therapy. I mean, you can stratify and select some patients, but for the other patients you can do nothing. I think that having in your hands one imaging tool that can provide us a measure of some things. We can use this measure in order to modify the treatment procedures, not only just selecting patients, but also preparing patients for some things in order to have a better treatment at all. Because otherwise it is something that is more passive and not so much active from this perspective.
Yeah, so I think I fully agree. And this type of information only tells you whether it is getting there. It's not telling whether the drug is penetrating well, right? It's not telling whether the drug is being released from the nanocarrier. It's not telling you whether the drug is going into cells. But pragmatically speaking, this is the best we can do for now. And I envision that, and hopefully in 10 years from now, we will be doing MR-PET hybrid, with PET looking at the accumulation of the formulation in different types of lesions, metastasis and solid tumors. And maybe some smart MR approaches like diffusion-weighted imaging that tells us something about diffusivity of molecules that can be used as a measure to predict penetration. And if penetration is good and accumulation is good, we have to make sure that the formulation releases a drug, right? That's something we can even do preclinically up front. Then I think that this will be valuable. It does not help those patients that do not accumulate or that do not penetrate. We will have to find other treatments for those anyways. But it would make the treatment more efficient. And I, in particular, think that in clinical translation, it will help a lot. Yes, Tracy, then there.
Well, very, very impressive, powerful methodology. I think if everyone, as the previous guy said before, actually it's a must to have EPR visualization, see what extent we have it. But as already said, that's not enough. And actually, you know, in some cases, it may be even misleading. I think we have to, the issue we have is if we compare different nanoparticles used for drug delivery to tumors, in most of them, unless they have a targeting device, and even this, in many cases, it's not correct, they are not internalized. They really stay at the tumor interstitial fluid, sometimes attached to the cell, sometimes not, sometimes attached to the collagen, sometimes not. A kind of distributed in a very uneven way, and everything dependent on the level of drug that will be released. Can be enzymatic mechanism, can be other mechanism. We can talk about the mechanism in a minute, but basically without this release, nothing will happen. And the best example is cisplatin in liposome. It concentrated in huge amount in the tumor, and the activity is exactly zero. There is no activity. So the fact that a lot of drug went there and you can see it with any imaging technique you want doesn't give you any benefit in this case. Of course, if it would not be accumulate, then you don't expect nothing. But even with the accumulation, actually, you know, you said, I'm expecting activity, but then nothing happened. So you have to be very careful. So what I'm trying to say is something very simple. Without understanding the mechanism by which the drug has to reach the cell, the target cell, the tumor cell, we have all this is a nice work, but it will not lead us very far. I think what we need is really to understand the way different nanodrugs release their active pharmaceutical ingredient in order to get us the real activity we look, which means to kill or modify or do something to the cancer cell. I think that's critical, or in some other, maybe to other cells, whatever is the target. So, you know, my small contribution is to try to understand how doxil work, okay? And from what I can see, and that at least I see one factor that present in the tumor interstitial fluid. This is the ammonia that produced there continuously. The tumor cells are ammonium or ammonia generators that generate ammonia all the time from the glutamine, releasing this ammonia. And this ammonia we can show very clearly, and actually a paper that I submitted should be published soon in, I don't know when, it was accepted to Nanomedicine, NBM, so I don't know when it will be published about it. we can show it, and actually there are ways to image tissues that produce ammonia from glutamine. Okay, there is a way to do it. Actually, it was done already, and it proved that this is a better way to predict about active tumor than to do regular PET scan with the glucose analogs. It showed much better results, much more specific, because this does not happen in a case that you have inflammation, but it does happen typically in tumors. So you can be selective. So what we have to find is a mechanism by which the different drugs are released from the different systems, then try to find the imaging way to image it, and then we overlap the imaging for the EPR with the imaging for the activity, and then our prediction might be much better. And I think that's probably will enable us to get much closer to the question when we'll be successful with these nanoparticles.
Yeah, thank you. There's still very much more work to do. So one last short question.
A very brief note and a short question. The brief note is that you showed very elegantly that how diverse and different a tumor or a patient's, particularly even one type of tumor is. But they also use the name nanomedicine. And nanomedicine does this. Then what you really mean is the one I used shows that one. So there's this incredible large variety of different agents. And we do have, I can feel that we do have a drug-centered view. Here's the drug in the middle of my word, and I look out for everything else. The question is, that was the comment, so be careful with the words because a lot of people are reading.
Yeah,
and,
sure. There is actually a table in this paper by Harrington et al. Showing that indeed there is this variability. There are breast cancers that have 10%, and there are some that have none.
Yeah,
this is the overgeneralization of the bigger picture.
Yeah, exactly. So the question is that if it is, isn't it possible that whatever you use is perfectly capable and useful? Is it the patient selection criteria that is not right?
Initially, based on what would you just say we're not doing Doxil anymore in breast cancer because we assume?
No. You select 100 patients. It says 50% of them is whatever particular drug it is effective. Another 50% is ineffective. Isn't that possible that the patient selection criteria is not right? So we are trying to refine how to select these subgroups that actually whatever we have is perfectly efficient.
I think that's what we're trying to do via imaging, to make sure that the patient selection criteria are a little bit better. And maybe you can do it with biomarkers like circulating, I don't know, VEGF or interleukins, I don't know. But that's where we need to be going in the future. So Albert, I'm not sure if it was a very short comment or question, but I think we have to.
I had a quick comment on what you suggested, that perhaps the blood vessels of metastasis or the tumors in the metastasis are retaining more liposome. They could retain better the liposomes if they were actively targeted. Well, I think there is something more than a question of retention because I go back to the work done with anti-angiogenic agents in breast cancer, particularly sunitinib, Sutent. And this work was done initially on models of primary tumors subcutaneously implanted in mice, and led to 2 or 3 phase 3 studies. Probably a couple of $100 million were spent to demonstrate that sunitinib was ineffective in metastatic breast cancer. And as I think, as I mentioned to you in one of our meetings, a couple of years ago, Dr. Bob Kerbel did publish work in which the breast cancer models were done in metastatic mouse models, and in those models, sunitinib was ineffective. So there is something about the biology of these blood vessels that I think is the critical point, which reduces also the uptake of nanomedicines in those tumors.
Yeah. That's a nice way to close it, because there's indeed not only the biology, but also the accumulation. We're just starting to look at that, right? And we really want to understand how things are working in order to make treatments more efficient. Good, then we rapidly move on. I'm sorry for taking a little bit more of your time. We move on to James Gubbins from the University from the University of Manchester. We'll talk about ICG-loaded and doxorubicin-containing liposomes for theranostic applications. Yes, please.